I am pleased to introduce our first two presenters, Joanne Rash and Megan Peterson, who are from the University of Wisconsin. Joanne has worked at the UW Carbone Cancer Center on the gynecologic oncology team since 2006 as a physician assistant. She sees patients in collaboration with a team of physicians as well as in her own independent practice. And I actually had the pleasure of knowing Joanne since I was a medical student many years ago at UW. Megan Peterson began her work with the Division of Gynecologic Oncology in May of 2012. One of her priorities is improving communication about sexual health concerns between patients and providers. Their presentations will discuss provider communication, common complaints for women, and an approach to implementation in your clinic. We're so pleased they could join us today, and after their presentations, they will be joining us live for a Q&A session, so please enter your questions in the chat box as they're speaking. We will again be using this chat box to gather audience questions throughout the conference.
Hello, I am coming to you from Madison, Wisconsin, and I am excited to be talking to you today about sexual health for women. And we're going to talk about provider communication, we're going to talk about common complaints, and what some things we can do for those. My verbal disclosure that I have none, however, I will likely show you erotic flowers throughout our today's presentation. This is our WISH team. We've got Lori Seaborn, Megan Peterson, and myself in the photo. And our APP team, the PAs and nurse practitioner, we see people in the clinic, and Dr. Kushner is our medical director. So I really want to jump right in. I know our time is limited today. We've got a full agenda. So the first question is, do people really want to talk with their healthcare providers about sex? Like, what is this about? And so way back when, now in 2009, a poll of healthcare providers said that, they really rely on their providers to, the providers themselves rely on patients to initiate the discussion. And then the survey that same year found that patients prefer that healthcare providers bring it up. And so what does this do? It means we're not asking and they're not telling and nobody's talking about it. And so that's the whole purpose today, is to really say, okay, where do I fit in? What's my role? What am I comfortable with? Where do I go from here? And so that's what this first section is about. How do we start talking with folks about this topic? So why don't patients ask? They ask us lots of questions. Why don't they ask? Well, they feel embarrassed, right? If it was important, we would already have been asking them, right? Maybe it's a risky topic. They feel like, well, I don't want to distract them from my cancer care, and what are they going to think about me if I ask them about sex, right? And so people worry that they're going to be seen differently. And so people don't ask. Why don't providers ask? Well, I don't know. I don't want to embarrass anybody. There's only so much time in a day. How do I fit this into all the other things that I do is a real issue. I didn't get trained on sexual medicine much at all during PA school, right? This topic found me and I had to go seek out my own resources and education. And so that's real. And so we make assumptions about our partner with our patients. We, assume that they'll bring it up, but that's why we don't always ask. And so, what does the World Health Organization tell us to do? Well, they clearly state that our healthcare providers have a responsibility to promote positive sexual health and positive, healthy societies. And so with that, we're going to launch into, now what do we do? Now that we know that the onus really is on us and we should be engaging with these conversations with our patients, what are we going to do? So I like to look at different models and frameworks to kind of help me work through my day. And the PLISSIT model is one of those that I just think lends itself really beautifully to our line of work, right? We give people permission to talk about it. We give them some information, maybe it's education. We give them some specific suggestions, and then maybe we need to send them for intensive therapy. And so that's the fast story of how to do the PLISSIT. But really, it breaks down this way, right? We want to legitimize their concern. Yes, we hear about it. It's common. It's common enough for me to ask you questions about it. It's common enough for me to know, common things to review and make sure I ask you about are coming, they're coming. But it's important that we think about those things and we give people permission, like, would you like to talk about it today? Would you like to talk about your next visit? Do you want to set up a visit just to talk about this topic? Right? There's a whole bunch of things that we can do that just gives patients permission to say, I'm not alone. And that in itself can be very therapeutic. We give people limited information, right? Cancer treatments commonly provide these issues. Are you having some of those? That's a great way to kind of approach it from an educational standpoint. There's specific suggestions. Okay, you've got dryness, try a lubricant, right? Oh, okay, what used to work, maybe we need to learn another new technique to try to aid mutual satisfaction with your partner, right? There's some suggestions we can get to, and we'll get to in the second half of my talk. And then there's intensive therapy, and that's sometimes where we need other people's help. I think of pelvic floor PT, I think of sex therapy, I think of couples counseling or health psychology, right? There's a team of people that we can surround ourselves with. We don't have to do all the work as providers. We've got our team of people to support that person, and that's equally important. So intensive therapy rounds out the Plisset model. So what do I say? Where do I start? Well, be reassuring, be communicative, be non-judgmental, all those things you already know how to do every day, right? If possible, include significant others. That's sometimes very nice. Other people would rather start talking to you on their own and just ask, right? If you don't know, just ask. Start with factual information and kind of move towards sensitive areas. I'm going to give you some suggestions coming up. What are you going to try, right? Are you sexually active? How has being ill changed things with your partner? Has surgery impacted things? Has hormonal therapy changed anything? Tell me about your functioning. Tell me what you're noticing. And so that's a place to start. From a sexual health history, if people come to the Wish Clinic, we kind of dig in, right? And you can decide how much of your practice do you want to ask and refer, or do you want to ask and then start to dig in a little bit? So this is what we do in the Wish Clinic. So what brings you to the Wish Clinic? I like to start with a really open-ended question before we kind of narrow things down. I want to know what's currently happening. What's their current are they kissing? Are they holding hands? Has all that stopped? I need to know where they are on the spectrum of intimacy.
Wondering
and there's lots of questions you can ask, or just have people tell me what you're doing. I want to know what things were like before cancer. It's sometimes really common for me to start with, tell me what brings you to the Wish Clinic. Tell me what things were like before cancer. Why do I start there? Because that's easy to talk about, right? When things hopefully were okay and better and kind of like a rhythm, well, then that's easier to start a conversation. They get used to me, and then we build rapport, and then we get into the nitty gritty of okay, cancer came into the picture. Tell me what's going on now. And so that's sometimes a nice transition. So I like to ask about what happened before, what's happening now. I always ask about partner and their relationships. You learn a lot about people by just saying, tell me about your partner. There's very nice things that are said about partners. There's lots of frustration that you sometimes hear as well. And so just having that awareness is very, very helpful. And I always ask about menopause. I want to get a sense of where they are. And then we always, always, always end that kind of history taking piece of the visit with what's your goal? Because I can hear all this, I can think I understand it all, but yet I don't know her goal. And so asking straight up is a great way to understand what people want. I'm going to kind of cruise through this. This is the additional health history. So don't forget the rest of her, right? Think about her gynecologic history. Think about past medical history. Is there anything in there that could impact function? Think about surgical history, right? Medications that they're on. Think about what's your partner like? Any troubles with their sexual functioning? That's really telling. Part of that history earlier on might have included, for same-sex partners, is there anything going in the vagina or not, right? That's important to know what is part of their sexual play. Prior trauma and abuse, I want to understand that. Exercise and diet, how overarching healthy are they, can be very helpful. And then I just gave you resources here. So I'm hoping this is included, or you can come back to the slides and look at this. But this is a great place to look for some resources. And so I'm going to pause here. And then I'm going to join back up here in a minute. Let our great facilitators today kind of talk about what I've presented. So we're back, and we're going to talk about common complaints for women after cancer and in general. So sexual complaints for women are common. And I think it's important that we all just recognize that this happens throughout the spectrum of life, right? So common complaints can be interest, lubrication, arousal, there can be pain, orgasm issues, and women commonly have more than one concern. Sexual arousal and response do change in time, and that is true for both men and women. So I think that's really important that we think about our partners, right? They might also be experiencing changes as we all age. So aging changes things for us, chronic illnesses, menopause, with or without children in the house, right? Partnered or not, and cancer or not. And I like to stop and talk about menopause, because many of the issues that we see in the Wish Clinic really stem from menopause, and it's menopause that happens sooner than planned. And so that's dryness, that's pain. But these women also have hot flushes and night sweats and sleep problems. And so just thinking about putting on your menopause hat for a moment can be really helpful. We know that cancer therapy induces change, right? Surgery, we put people into surgical menopause. We remove tissues that are sexually stimulated, right? Chemotherapy, radiation therapy, anti-hormone therapy, all of these things impact how our bodies function. So surgery, I'm not going to spend a huge amount of time on this because we're doing the speed course today, but surgery has lots of effects, and you can read those there. Chemotherapy, think about dryness, think about mucous membrane changes, think about desire and fatigue, and then you kind of get this picture of like, yes, chemotherapy impacts people's daily function, let alone their sexual function. Radiation therapy, think about how that tissue changes from an anatomy standpoint, right? The rugae, the folds of the vagina flatten and go away. Burns, skin burns can happen. People have bowel and bladder implications if the radiation's pointed in the pelvis. So really thinking about where was the radiation pointed and how is that impacting tissue is very helpful. And the one I want to really point out is vaginal tissues and vaginal shortening for anyone with pelvic radiation therapy. Hormonal suppressing therapy, right? So we have a young lady with breast cancer on anti-hormone therapy, and that just takes away all that estrogen, right? We're putting her into a medication menopause, right? Think of it that way, and then use all your menopause tricks for her. And then there's psychosocial challenges after a difficult diagnosis. And I think this is where partnering with our health psychology teams, partnering with our physician teams and the treating oncology teams is really important to really help figure that out. Don't forget your social workers. They're great with this as well. I wanted to plug that in as well. So financial burdens, loss of independence, just the fact that the foundation of your life was shaken up and now you have to kind of find a new firm foothold is important. And that creates lots of emotions for people: anger, depression, anxiety. How do I talk to my partner about this without overwhelming them about my fears and concerns? So this is a really important area as well to focus on. All right, we are going to start back up with arousal and interest. So I always think about arousal as, okay, is there anything else underlying going on? Because if it's from physical pain, for example, like who wants to do anything that causes them pain? Nobody, right? So figure out if it's physical pain that's really causing the decrease in arousal and interest, and then go back to the previous section, right? Is there anything else going on from an underlying medical condition? Can't blame cancer for everything, plenty of things. But maybe there's some diabetes, or maybe there's some neuropathy, or maybe there's some mood and they're on a medication that's changing things for them. And so think about globally the person as well from the cancer view. So think about those things. And then I also think about, how do people feel about their bodies? How is their communication? What's going on at home? What's their stress level and their mood? History of sexual abuse and trauma. Those things sometimes kind of bubble up to the surface during cancer care. And so getting into some of that can be really helpful. And then getting your team involved, right? Whether it's an individual counselor, sex counselor, couples counselor can be really helpful. And then there's some more suggestions as well. So reviewing again about what's going on, what's happening, how many things are they juggling? Are they distracted? Are there too many other things? Remember that Maslow pyramid where, if you can't have food in the house, you can't get to the next level. And, sexual functioning is kind of on the higher end of functioning and levels. And so how do we break it down and make sure that we're getting those other pieces under control? And that's where our team of pro and social work and health psychology can be really helpful. sex therapy is great. So if you can find a sex therapist in your area, think about sex therapy and referring to those folks, whether there's maybe a religious belief that's kind of dampening things, something that was said in upbringing that is hampering things. Those things sometimes come out. And so talk about that and have those folks ready for referral. Individual counselors for like body images post, maybe mastectomy, for example. Marriage counselors, if there's stress in the relationship, is really important. And then Addyi is on the market. Addyi is approved by the FDA to help with premenopausal women with hypoactive sexual desire disorder. And so Addyi can be helpful. It's FDA approved. I have never prescribed it. I must tell you that I have never prescribed this medication because it's not approved in postmenopausal women, which is a lot of people I see, and it's not been studied in cancer patients. So, but it is out there and you might get asked about it, so look it up. And then we think about orgasmic issues. So difficulty with orgasm. I think, medication is one of the things that come to mind. Or I think, was there a structural change that happened with surgery, for example? And what can we do for that? I also want to make sure it's her goal to orgasm. Plenty of people may not have an orgasm on a regular basis, but still feel emotionally close to their partner. And that is fine too. So orgasm, I kind of tiptoe to try to figure out if this is your goal or not. Vibrator therapy to bring blood supply can be helpful. Sex therapy, I talked about that. Erotica and engaging the brain is really important when we think about libido, when we think about orgasm. How do we get the brain to really kind of help guide the body instead of waiting for the body to tell the brain that it's interested, right? So sometimes a relearning of where we want those messages coming from. Sensual touch and massage is really helpful. Intimacy. So I like to leave people with this section, and I'm going to read it to you. So I like to remind people intimacy and closeness and love is more than intercourse, right? Everybody needs to feel the kind of closeness that comes from being held, kissed, loved, and hugged, right? Like just that importance of basic touch and knowing that they're loved. Intimacy and sexuality for women are often about feeling connected wholly to their lover, not necessarily about the act of intercourse. And so making sure we talk a little bit about that, being playful together, enjoying each other, being sensual with each other, even if the penis isn't going to go in the vagina, right? I think it's really important that we kind of help set maybe some new goals that can be really helpful. So talking to the partner outside the bedroom, getting to know your own body again, right? A lot of things happen, like how does it function? What feels good? And maybe I can tell my partner what to do, using body charts to help communicate. And I always have people think about why your partner loves you, right? Maybe they can write you a nice letter. Sometimes that's a lot to ask, but I sometimes bring it up because like, why do they love you? I bet it's not because the penis goes in the vagina. And then I like to leave people with this. Your sex life may have changed, but with creativity, playfulness, and patience, you can feel pleasure and stay connected to your partner. I think this is a great summary, very hopeful summary, and something that you can use in your practice. Here's my references. And here is our UW Health Gynonc team. Thank you. And I will stop my recording.
Good morning. I'm Megan Peterson. I'm happy to be joining you virtually today to discuss the role of advanced practice providers in sexual medicine and the development of sexual health programs. I have no disclosures. I have included a picture of the current contingent of sexual health providers. Lori Seaborn and Joanne Rash were instrumental in creating the Women's Integrative Sexual Health Clinic, or WISH Clinic, in 2014 with Dr. Krishner as our medical director. I joined in 2018. Our objectives today are to understand different clinic models, learn how APPs can provide care and expand access, and understand the steps to developing a sexual health program. Providers and patients may ask, why are APPs suited to the role of a sexual health provider? Well, we have advanced instruction and training with an average of 6 to 8 years of college education. As a group, we can take histories, complete exams, order testing and referrals for a wide variety of conditions. Our scope of practice can vary depending on our licensure and state of employment. It is beneficial to seek out additional training, either with sexual health programs such as ISSWSH, the International Society for the Study of Women's Sexual Health, or with a preceptor. Depending on your advanced degree, providing sexual health care to specific populations is within your scope of practice. Quality of care is often evaluated by practice patterns that include quality indicators, service utilization, and referral pattern measures. Systematic reviews do vary, but the majority find APPs to be at least equal to primary care MDs. It is also noted that APPs are more likely to provide more health education and counseling services. APPs have been utilized to mitigate shortages in U.S. primary care since the 1960s. And over time, we have developed diverse APP managed services and clinics. Where I work at the University of Wisconsin Hospital, we have survivorship clinics in oncology, we have procedure clinics, inpatient and outpatient teams, such as our multidisciplinary palliative care team, our inpatient atrial fib team, and our ostomy and wound clinics. There's no way to sugarcoat it. Sexuality is complex, and when you add a cancer diagnosis to the mix, the complexity only magnifies. A cancer diagnosis often brings with it its own set of psychosocial issues. As we were establishing the clinic, we had to decide if we were going to limit the practice to women with a cancer history or all women. In our case, limiting to patients with a cancer history made sense. We work in oncology departments, and sexual health is beginning to gain a true foothold throughout our cancer center providers. While they may not feel comfortable providing guidance for concerns, they are providing referrals for our clinic. Our patients have issues that are specific to cancer. Surgery causes scars. They could create ostomies, shortening of the vagina, or changes in sensation. Radiation causes skin changes like fibrosis. Chemotherapy can impact nerve endings, and aromatase inhibitors cause significant dryness to sensitive tissues. Another option would be to design a sexual health clinic model that cares for all women with sexual concerns. Across their lifespan, women can experience a variety of sexual health concerns. The changes in the tissues related to the loss of estrogen in the postpartum, peri, and postmenopausal states can be profound. A new symptom of urinary incontinence can be distressing, making women limit sexual play because of fear and embarrassment. Disorders of the vulva and vagina that impact the sensitivity of the tissues and the function of the muscles can change the sexual landscape for women after a period of normal sexual activity. Cultural expectations can also play a major role in women's sexual beliefs and behaviors. Sexual health care includes synthesizing the physical and physiologic concerns, as well as the psychological, relational, and cultural aspects of sexuality. Others will talk more in depth about male sexual concerns, but your model could also be a sexual health clinic that cares for men. Men have sexual health concerns that are very similar to women: libido issues, pelvic floor issues, cancer-specific issues, as well as erectile dysfunction and premature ejaculation. Our sexual health clinic is designed to complete a new patient intake over 2 visits. The first visit includes a detailed history taking about general health, sexual health, review of systems, partners' health, and relationship health. Sexual health information is gathered about what the patient experiences were prior to, during, and after cancer diagnosis and treatment. This visit allows patients to gain rapport with the provider and feel comfortable discussing sexual health in detail. At the end of the first visit, we discuss many of the psychosocial aspects of sexual health, including how common and normal it is to have changes with desire, libido, and sexual response after cancer diagnosis and treatment. The American Cancer Society actually prints a booklet about sex after cancer, and we give that to each patient and encourage them to share parts with their partner or all of it if it resonates with them. We offer a bibliography to each patient and point out books that she might find helpful in a multitude of areas. We also discuss ways to broach sexual health in a discussion with her partner. We see each patient back about 2 to 4 weeks after the first visit. The second visit is a review of any changes the patient has initiated from her prior counseling, as well as a detailed exam. The exam includes a complete physical, as well as a pelvic exam with speculum, bimanual, and muscle strength testing. Additionally, sensation testing, pain mapping, and dilator fitting are completed. A medical assistant can be utilized as a note taker during this exam, which is more cost effective than a second provider being present. Counseling after the second visit includes physical exam findings and patient-specific recommendations. This is the time when you'll see us refer to pelvic floor physical therapy, sex therapy, discuss lubricants, moisturizers, and in detail, as well as discuss the vaginal renewal program with a vibrating wand. Additional visits are left open-ended. Some patients only come back 2 or 3 times. We have one patient that's come back to our clinic 8 times. Women may need ongoing encouragement or benefit from repeated recommendations. Engaging in change can be difficult, and having someone by your side encouraging you can be a game changer. I was a cheerleader in high school, and I can be a cheerleader for sexual health. If you're looking to develop a clinic, either cancer or benign focused, this is how our clinic got started. Keep in mind, this type of clinic is likely to be successful in many different areas: general gynecology, urogynecology, urology, oncology. Our clinic initially began with 2 APPs seeing the patient jointly. This allowed for collaboration, mutual learning, and mentorship. Collaborating with your partner. This is what I heard. What do you think about this? Allows each person to gain experience and knowledge more quickly. Allowing one provider to focus on documentation allowed the other provider to listen for key points and refine their interview skills. Many of us have experience interviewing patients, but need practice with sexual health so that our questioning can be smooth and comfortable. Developing a sexual health program requires legwork. First, support from administration is needed and essential before proceeding. Department and division chairs, as well as the Cancer Center director, who is pictured here, were supportive of the development of a cancer sexual health clinic and felt that it would further support the options for patients as part of our comprehensive cancer center. Our cancer center offers social work services, registered dietitians, health psychology, genetic counseling, and palliative care. Offering sexual health services just made sense. The APPs and the medical director did need to advocate for funds, which were provided. We also needed to advocate for access to support services. We were able to work with amazing public relations people who got the word out to our regional partners and our local departments. IT and scheduling assistants were also essential in building the department. Finally, you do have to carve out time from your current practice to allow for sexual health patients. So you have to have an understanding of your current demand for access. Lori Seaborn presented at Grand Rounds to promote the clinic among providers. An informational booklet about the clinic was developed with our public relations department and was placed in clinics throughout the cancer center. A sexual health department was created, separating it from all the other cancer clinics. This provided us with more visibility to other departments and made it easier for providers to efficiently enter an electronic consultation order to refer patients to us. Here is the cover of our informational booklet for our WISH Clinic, Women's Integrative Sexual Health Program. Our healthcare facility uses Epic for our electronic medical record platform. We were able to work with our ambulatory builders to develop a template for our visits. This template makes it easier for the MA to record findings as we're moving through the exam. There are areas in the template that can be selected with just a click and areas for free text for the provider to go back and add additional information if needed. We did contemplate restricting access to WISH Clinic notes, similar to how some notes require you to break the glass for sensitive material, but decided it would cause difficulties with our nurses and MAs. Which support staff do you have access to? What if they're not there the day you're seeing the patient? What if they change jobs? As you work to build the program, you need to build resources. We have partnered with 2 pelvic floor physical therapists, one on each side of town, who are employed by UW Hospital. We send them a message that we're referring a WISH patient, and they work to get the patient seen in a timely manner. Additionally, we meet every 3 to 6 months to discuss cases and provide each other with recommendations. We've also connected with a certified sex therapist who works within our system and a therapist who works in the community with couples on intimacy concerns. We've developed a variety of patient materials drawing from numerous resources. We were able to partner with another sexual health clinic in the Midwest and incorporated some of their information into our educational handouts. Additionally, the American Cancer Society has an amazing amount of information on their website. They are moving away from print materials, so consider that with your patient's population and computer access and tech skills. A Woman's Touch is a sexuality resource center in Madison that is owned and operated by a medical director and an educator, sex educator counselor. They've worked closely with our cancer center on a variety of projects. They also have a great deal of information online, including free educational brochures that you can print and share with your patients. Each new patient does receive a folder after their first visit. We review common patient materials such as lubricants, our bibliography, highlighting areas of specific importance for patients. Additionally, each individual receives information tailored to their specific situation. I like to joke with patients that this is homework, and that's why it's in a folder. It's imperative to have an understanding of what a patient will be billed if their visit is not covered by insurance. We met with our coding and billing department to determine how many patients were being denied for their visits, and the findings were surprisingly good. We use the cancer diagnosis as our primary billing code, with sexual health billing codes being secondary. We've had significant interest from benign departments about creating their own sexual health clinics. And before getting too deep into the process, we recommend that providers understand what is the potential for insurance coverage and if their patient populations would be willing to pay out of pocket for a service if it's not covered. We also had to ask for coverage for nurse triage and in-basket. And from the start, the Wish Clinic has generated very minimal work for our nurses in the GYN-ONC nursing pool. Our approach has changed over time. We started the clinic with 2 providers seeing each patient. With experience and with an eye toward fiscal responsibility, we have moved to seeing patients as single providers. This has enabled us to increase access, provide appointment options on multiple days of the week. And after 4 years, I was added. Let's not forget how COVID has also impacted the functioning of our clinic. We've been able to successfully transition about 30% of our patients for their first visit as a virtual visit. We do require video visits so that we can build a rapport with the patient. And additionally, due to current reimbursement structures, our visits that are virtual can only be conducted with patients who reside in Wisconsin and Illinois due to our licensing. This process has been very successful and appreciated by patients, and we find the majority of patients seem more comfortable and actually provide more in-depth answers in this setting. That is all for me today. Thank you for your time.
We're now joined live by Joanne Rash and Megan Peterson, who will be taking questions. Thank you, ladies, for getting our day off to a great start. So my first question is for Joanne. What are the top 3 resources to make available to my patients regarding sexual health?
A great question. Are you hearing me okay? Yes, perfect. So I always think of resources as print material. So creating a bibliography or a handout of that, something that you want to give people can be really helpful. So listing resources for people is number 1. Number 2 would be lubricants. So reaching out to different companies, getting some samples, so that way you have something to actually physically hand somebody and say, try this. I find that if you give people a resource, they're more apt than if you give them a list of things to try to go out and find and buy, right? So if you have...
Thanks, Joanne. I think I'm going to ask Megan a question next, if hopefully we have her here. Megan, how difficult was it to secure support from your cancer center to develop this program?
Well, I want to caution everyone that it might not be as easy as it was for us. We, at the time, had a chief nursing officer that was very proactive about survivorship and very much wanted to promote different options available for our cancer center. As we mentioned before, we had a nutritionist, we have health psychology, but we did not have sexual health, and they realized that that was truly a need for so many patients that it was actually quite supported. Dr. Kushner, as our medical director, he continues to go to leadership and say over and over how much this clinic is needed. And I think they realize as time has gone on how many different groups in the cancer center do refer to us. So it was surprisingly easy to get funding, but caution, it might not be that way with every facility.
Joanne and Megan, thank you so much for your input there. And you both specialize in sexual health for women, and I specialize in sexual health for men. And what I've noticed is that a lot of these important points that you made are actually relevant to people anywhere along the gender spectrum, whether it's the importance of lubrication and hormones and early intervention and pelvic floor physical therapy. And I've just been amazed at how similar actually all of those care is, regardless of the gender of our patient. And I do want to touch on the points about the importance of, one of the hats that we wear as healthcare providers. Yes, we're taking care of the patient in our office, but advocacy is so critical in going to the key stakeholders at our institutions and our care programs to really advocate for our patients, to say, look, if we are doing these treatments to our patients and there are known sexual side effects, we have to address and treat the sexual side effects. So the advocacy point is so critical.